Hi, everyone. Welcome to today's seminar on integrating care for dually eligible beneficiaries. I am Rachel Warner. I am the Executive Director of Penn's Leonard Davis Institute of Health Economics. We have a lot to talk about today, so I'm just going to jump in with a little background. There are more than 9 million people in the United States who receive full benefits from both Medicare and Medicaid, commonly known as dually eligible beneficiaries. Medicare covers the medical and pharmacy benefits for this group, where Medicare covers co-pays, premiums, and long-term care generally. Dually eligible beneficiaries make up a particularly vulnerable group. They are people with low incomes, high rates of disability, and other complex health needs. About half of people are individuals who are people of color. About 1/4 have 5 or more chronic conditions, and a high proportion have serious mental illness. Caring for this group is expensive, costing roughly $500 billion per year. It's also complicated for the beneficiaries. In theory, these two programs, Medicare and Medicaid, provide comprehensive care. But in reality, individuals must navigate two separate systems and two separate programs, which often have different and at times conflicting rules on eligibility and benefits. This lack of coordination between the two programs can lead to worse outcomes for individuals and higher costs for the population, as well as confusion and frustration for those who are trying to access care. This isn't a new problem, and it's not a new recognition of an old problem. There are decades of efforts to try and address these challenges. There have been many possible solutions and demonstrations, particularly over the past decade. Things like special needs plans, which are administered through Medicare Advantage and offer varying degrees of integration and coordination. There have also been demonstrations under the Financial Alignment Initiative and other efforts as well. Despite these efforts, progress on creating integrated and coordinated care for dually eligible beneficiaries has been slow, and progress has been disappointing. With this background, earlier this year, in collaboration with Health Affairs and with funding from the SCAN Foundation and from Arnold Ventures, we gathered at Penn's Leonard Davis Institute with a group of experts from across the country. These experts represented beneficiaries, state Medicaid agencies, private insurers, the Centers for Medicare and Medicaid Services, providers, and others. Our goal was to build on what we know from past efforts to integrate care by considering what a successful path toward integrated care for all dually eligible beneficiaries would look like and what it would take to get there. Our panelists today participated in that conversation, which resulted in a background paper and a policy brief, which is available at LDI's website. We're here today to discuss those policy recommendations. So with that, I want to introduce our panelists so they can take part in this conversation. We are joined by Aisha Atkins, who is a caregiver to dually eligible beneficiary and an advisor and organizer who works to build an equitable, inclusive and comprehensive healthcare system. Toyin Ajayi is a physician and is the CEO and co-founder of CityBlock, a provider organization providing primary care, behavioral health care, and social services to low-income individuals with complex needs. Matthew Behrens is a senior policy advisor for complex care and duals integration at the Virginia Department of Medical Assistance Services. And Melanie Bella is the former director of the Medicare-Medicaid Coordination Office at CMS, is also the former chair of the Medicaid and CHIP Payment Advisory Commission, or MACPAC, and is currently an executive advisor at Cressy & Company. So our starting place for our conversation over the summer and for our conversation today was based on the following. We know that incentives for the current system are a problem because Medicaid has no financial incentive to spend money on services that could help individuals avoid Medicare reimbursed care, such as hospitalization. Similarly, Medicare, or in this case, Medicare Advantage plans, have financial incentives to shift the cost to Medicaid when they can. Aligning these incentives to support efficient care is essential, though it's easier said than done. And we know from recent experience that financial integration alone isn't enough to drive integrated care experience at the beneficiary level. So that was our starting place for our conversation. From there, we spent about a day and a half together with about 25 other people and came up with 6 recommendations to support enrollment of dually eligible beneficiaries, integrated options, and among integrated options, increasing financial integration and accountability. So I want to take a deeper dive into these recommendations one by one, and I'm going to start with the first recommendation, which in many ways appears to be the most straightforward recommendation. That recommendation is that every state should offer at least one integrated option for all dually eligible people in their state. And Melanie, I want to turn this to you first, so you can tell us why this is an important recommendation, and maybe tell us a little bit about what the current state of affairs looks like, why we even need to do this.
Thank you, Rachel. And this is such a straightforward recommendation, but I think I could spend hours talking about like why it's been so challenging. But I appreciate so much that you held this convening and for the funders who supported it. I would say, I mean, as you alluded to, I mean, this recommendation is premised on the hope that every dually eligible beneficiary in the country has access to high quality whole person care. And the availability of integrated options varies widely across the states. Some states have a lot of options, some states have a few options, and others, for very legitimate reasons, haven't been able to do anything to date. The paper discusses some of those challenges, but importantly, also offers concrete recommendations for how to get to a point that every state has at least one option where there is a single entity that's administering both Medicare and Medicaid benefits and bearing some degree of financial risk for the Medicare and Medicaid spending. And does, in my admittedly biased opinion, a nice job of being very specific about where Congress could act, where CMS could act, and where the states could act. I would say when we're talking about what that might look like, the financial integration and having the one entity responsible for Medicaid and Medicare is important, but also is the notion that you mentioned about looking at the integrated experience for the actual dually eligible beneficiary. So thinking about one card, one handbook, one network, the kind of this notion of one, and allowing for a more integrated experience. So people today are just the experience for people, unfortunately, is it's all over the place. It is a very complicated system. We have seen a growth in integrated products across the states, but still, the majority of duals do not receive Medicare and Medicaid services through the same organization. And we also still have a proliferation of non-integrated options out there. So when you are a person who's trying to make a choice about how to get your care, you're bombarded with things, but the majority of them are very confusing. They don't help you coordinate between the two programs. And there's still a lot of cost shifting, which at the end of the day doesn't usually end up in the individual's favor. And so we're really hopeful that we can support states in being able to offer everyone in their state access to something that lets them take advantage of the fact that they have entitlement to both of these separate benefit packages. In the
Thanks.
interest of time, I will stop there. And obviously, I know that my fellow panelists have a lot to say on this as well.
Absolutely. Thanks, Melanie. I welcome the other panelists to jump in and on those. We have a lot to talk about, but I think all of you have a lot to say about this issue. Matthew, do you want to jump in?
Yeah, sorry. Probably saw me struggling to get off mute there. But yeah, I wanted to put in a plug for one of the recommendations in the policy brief, which was seed money or kind of planning grant money for the states. I think that that's incredibly important. In Virginia, our experience is a little bit different. We started with financial alignment demo, and we've moved to DSNPs and trying a few different things. So we've had kind of a little bit of a commitment to this, but it is incredibly difficult from a state if you're kind of starting from scratch. Trying to balance this with other priorities. So even in planning grant for something to like reach out, like stakeholder engagement or helping the state learn how to move down an integrated path, like using data is like using kind of the coordinating across the CMS data and the state data, that's incredibly difficult. It takes a long time to learn that. So any type of resources that can be given to the state to help them along that journey would be hugely beneficial.
Yeah, and I appreciate you saying that. And I think that one of the things that we talked a bit about is why there are so many states where there's not a truly integrated option that's widely available to all beneficiaries. And finances is certainly one of them. I think the other thing that Melanie alluded to is that a lot of states, in a lot of settings, there are plans that are available, but they're not actually integrated. So we sometimes refer to those as lookalike plans. And that may hinder our ability to get all beneficiaries access to a integrated plan. Does any of you want to comment on lookalike plans?
I can. I mean, I can say, I mean, this is, we have many plans that have figured out, I'll just be blunt, how to make money on dually eligible beneficiaries without helping coordinate or integrate their care. And so CMS has done a great job of trying to crack down on that and trying to support states in addressing getting rid of non-integrated options. It's not just lookalikes, it's some of the chronic care SNPs as well, who we see are going after dually eligible beneficiaries disproportionately. So the more we can do to support the chosen path that a state has and make sure that other alternatives that compete against that integrated option aren't available, I think the better we can support beneficiaries and their caregivers, helping them make choices, as well as the states.
Mm-hmm.
I think the other thing that I would add is, as we craft recommendations, and I think as policymakers, recognizing that this stuff is incremental, it takes time. And I think for a long time, there's been a real focus on getting people into managed care, giving people options to be in managed care because we believe that that creates the opportunity to be more flexible in terms of benefit design, to require and measure care management, that it will create incentives for managed care organizations to focus on experience and quality and total cost of care. And then I think we are learning that in order to achieve really all of the gains that we're hoping to get in terms of outcomes and the experience for dually eligible folks, we have to be much more specific. And so, really saying, instead of a goal for what proportion of beneficiaries are enrolled in managed care, should we really focus on saying the integrated part is really important, and ensuring that we're really going towards that as stakeholders and policymakers, and figuring out how to incentivize that in the ecosystem writ large. I think it's a really, really important point, to just make sure that we're focused on what the end result that we're hoping for, and what the steps that are necessary to get there. And we're moving along that continuum, but we still have a way to go.
So Aisha, I want to pull you into this conversation. And one of the things that we know from the past decade is that making integrated plans available to dually eligible individuals is not enough. There have been a lot of efforts that made these plans available, but there wasn't uptake in enrollment. And I think that that led to a recommendation that we needed to make it easier for beneficiaries to enroll in these options. Can you tell us a little bit about the process of choosing a plan, and from the perspective of someone caring for a dually eligible individual, what that process looks like?
Yes, certainly, Rachel. I think I can oversimplify this by saying that the process of enrolling someone who is dually eligible, in this case, my mother, was incredibly confusing. Certainly, as someone who does not have the language of, who's not fluent in the language of Medicare and Medicaid, being able to navigate these separate systems in a way that is beneficial to the person who would ultimately be receiving care and who would be the beneficiary, was incredibly frustrating. Everything from the accessibility of the site to the language used, understanding the different plans, the layouts, what is available, the consequences of choosing a particular plan, all of those things, and then how the two plans work in tandem, the availability of benefits under each plan, and under each program, and how those differ, was certainly something that I had to learn, that was kind of trial by error. And unfortunately, I think a lot of consumers find themselves in this exact position where they are forced to learn kind of on-the-job training, right? And it's not something that we are well versed with as a society until we are faced with the need to access these benefits. So there's a lack of consumer education that exists, and I think that it is the responsibility of these programs to make that education, make those resources available. But I think that by streamlining Medicare and Medicaid, by making them, by integrating them, that's one way to decrease the amount of information that is necessary to access. And also, you are enabling consumers to really take a closer look at what's available to them.
Yeah, and so it's definitely a confusing landscape in choosing plans in general. And then I think layering on top of that, the benefits of an integrated plan over other plans has been difficult to understand for many consumers, if I can so summarize what you said. Matthew, how do you guys think about making this easier? Like, what do states need to do to make it easier?
Yeah. Education outreach is really difficult. We are here in Virginia, we're getting ready to move to exclusive line enrollment. So won't get into it at the moment, but it's a big shift for our DSNP and kind of how we work with our DSNP and our Medicaid managed care and integrate those. We've done a ton of outreach and education as part of that. And I think it is reflects a lot of what Aisha said. Even working with provider associations who I work with duals on a daily basis, they didn't really have the language to understand it. They have questions about, well, how do we do cost sharing, the crossover claiming and that. And so it's been really eye-opening just to see like just how little we have the information we have out there. So I think that'll be something we'll take and go forward with. Is like we just need to continuously do stakeholder engagement and outreach. But I do want to say, and I don't mean this as a shot at CMS because I'm sure there are probably people out there, but I do want to just as an example of how this is hard. Yesterday, I went into Medicare Plan Finder, pretended I was a dual, and 57 plans just in my zip code available for me. And if you go into the Plan Finder, you have to kind of scroll different pages. It took me to the 4th page before I found a DSNP. So all the ones that were ahead of that were all non-integrated plans. So dozens, like probably 30 of those, 40 of those, right, were non-DSNPs. And so we've spent a lot of time working and providing an integrated product, and it's not the first thing that kind of pops up for members. And so that might be kind of something a little bit easier to fix and to hopefully make it a little bit more apparent and hand it to members a little bit easier.
Right. And so I think this is something that people refer to sometimes as choice architecture, which is making it easier for people to make the choice that might benefit them the most, and putting for dually eligible individuals, putting the integrated plans at the top. Another group that we talked a bit about needing to educate about the enrollment or the advantages of the enrollment in integrated plans with providers. And so often patients go to providers for advice. And I think providers are equally confused about what the options are, may not have incentives to get people into the integrated plans because of narrow networks or worries about changing in providers, and can't offer the support that people are looking for. And so that was another piece that we often talked about. I don't know if anybody wants to jump in on that.
Oh, Toyin, you should go.
No, you go ahead, Mel.
No, you are the provider organization.
I know we're going to build on each other. Oh, okay. All right. Well, I would say, I think that's absolutely true. I think there are foundational issues that stem all the way back into sort of medical education and the administration of care delivery, which is that clinicians are not often taught about insurance, period. They're not taught to understand or discern. And they certainly don't get like intentional immersive education about what the experience is from the consumer, the member's perspective. And that's a real problem. What that results in is that they're optimizing for their ease of their daily work. And so it creates a real onus both on the plans to show the value and be discernible to the providers, and to ease their administrative burden, because that's often one of the biggest challenges that they're facing, in order to create that sort of goodwill and brand and understanding such that providers would actually know to recommend it. It's a lot. There's a lot of ground to cover. And so, I do think that there's an opportunity to target specifically providers caring for these populations with really nuanced and well-designed education so that they understand the implications of insurance and coverage type for the people whom they're serving. And then it creates, I think, the right incentive for plans to be differentiating and to be value added, so that not only does the member and their family see the value of being in an integrated product, contract, but so too does the primary care doctor who's caring for them and making referrals for home health or for a DME in the home. They've really got to be able to see that it adds value to them and to the patient that they're caring for.
Well, not to spoil where we're going in the future, but I mean, when we did talk to some providers after some of the financial alignment demonstrations, they have no idea what these acronyms mean, right? We talk about FIDEs and HIDEs and MMPs and PACE, and it's just they're kind of like they had no idea what the sort of coordination resource potential and integration potential was. And so I think to Toyin's point, helping them understand that. But a point we will get to later that's discussed in the paper is the rise in ACOs. And so when you have then providers who are in ACOs, they don't seem to be understanding the integrated options in the same way. And so it makes it hard to have that clinical and financial integration if we don't figure out how to tackle that group of providers for the number of duals who are in fee-for-service delivery systems and in those mechanisms.
I want to move on to a third recommendation that we made, which is also focused on improving the experience of beneficiaries, which has to do with continuity of coverage. And the recommendation was to simplify and improve Medicaid eligibility and enrollment process to promote continuous coverage, specifically 12-month continuous coverage. And we certainly know from our past experience at the end of the public health emergency, then the Medicaid unwinding, that there is a lot of administrative burden to re-enrolling in Medicaid. The dually eligible population tends to be continuously eligible for Medicaid, and so this may not be a huge burden on Medicaid to keep people continuously enrolled, but one that really benefits people from an administrative standpoint. Aisha, do you want to share your thoughts about that?
Certainly, it's something that I feel strongly about. I think that that automatic eligibility enrollment, re-enrollment every 12 months, I think is beneficial. I think that it's something that it will decrease the burden or the onus on the beneficiary to have to like prove burden of care every 12 months. And this is, I think, particularly beneficial for those with degenerative diseases, progressive diseases, for whom their conditions will not change over the course of the remainder of their lives. In fact, the need for care will continue to increase over the course of their lives. And so I think that making sure that there's a continuation of coverage, continuum of care that takes place really does lean into that, the idea of whole health and really person-centered care by enabling that continuation to go on rather than risking potential interruptions in care and potential disruptions in the way that the care is distributed.
Yeah. Thank you. Others thoughts on continuous enrollment?
Just to build on Aisha's point, I think just to remind us in the audience that many folks who are dually eligible almost definitionally are dealing not just with physical health challenges, but also with a lot of the sequelae of having low income or social drivers and social barriers to accessing care. And so, a meaningful proportion of the folks that we serve who are dually eligible are marginally housed or struggling with housing insecurity. Things that seem simple, like receiving a mailer at your home address and being there to pick it up and filling out a whole bunch of information and mailing it back and waiting for a response, or having access to a safe and secure computer into which you can upload documents and navigating the portal are really meaningful barriers for many people and create a level of friction that can be prohibitive in terms of their ability to maintain coverage that is so critical to their care. And so, while we have seen a lot of kind of advances in technology in general, I think one place where we still experience a lot of friction and a lot of manual processes are these administrative processes for a population of folks that have so many other things that are equally, if not more, pressing on their day-to-day plates to manage, and that becomes a real challenge for folks who may need it the most.
maybe I'll push on. So we've talked about three recommendations which are meant to support enrollment and beneficiary enrollment in integrated plan options, increasing options available, making it easier to choose the integrated option, and making it easier to stay enrolled. Can we just talk for a minute about like how to actually accomplish those, who needs to do what if we were really going to make progress on those things? And this was something we spent a lot of time together talking about, because there's a bunch of different players who need to work together to make these changes. And so I think it's worth just pausing for a second to talk about that. And Melanie, maybe I'll ask you to weigh in on that if you don't mind.
Yeah, so I would start with what Matt said, which is we can't do any of this without the states, and we have to figure out how to support states build their capacity in around data and the ability to integrate data and understand their population and build their capacity around Medicare knowledge and support them with a base understanding of where their dual eligibles are today, where they are on the Medicaid side and where they are on the Medicare side, so they can see where they're going in terms of getting everybody in to have an integrated option. Congress could help. This is a bipartisan issue, believe it or not, and I think we have every reason to believe it will remain a bipartisan issue. There's been several pieces of legislation that have ranged from, support for states all the way up to creation of a new program and, flavors in between. And so figuring out what it would take, Congress actually hasn't acted on this since 2018. And so there is, I don't know how you make something a priority in the new Congress, but I think we should give it our best shot. And then CMS has done a lot on the rulemaking front and making a lot of changes. I think, some things that get talked about are kind of a menu of integrated models for states. So simplifying what gets put in front of beneficiaries and helping states then choose one, and having a little bit more standardization over a smaller number of models, I think are other things that might be helpful. But nobody can do it. Well, Congress could probably wave a magic wand and do and kind of do it all. But we really need to figure out ways for Congress, CMS, and states to all move in the same direction in service of the beneficiaries.
And Matt, do you want to comment at all on what you have the ability as a state to do?
Yeah. Yes. I mean, I think particularly with the idea of continuous eligibility, I mean, if it's a requirement, then it's not a particularly difficult thing to do. I do think there's kind of I think from a practical perspective, and maybe it illustrates this is really kind of a whole system approach, or we would need a whole system to help with this, is that a lot of times when someone loses eligibility because they just simply haven't submitted their paperwork, they find out about that when they go to the provider and the provider says, "Oh, you're not covered." And then they come back and they do their application, and at least in Virginia, if they do it quick enough, we can get them back in and everything gets retroed. And while that's messy, it is possible. So if we're going to go to 12-month continuous eligibility, there needs to be a way that somebody sees that, right? Because the problem still exists is that we sent information, the state sent information to the member didn't act on it or didn't see it for whatever reason. Maybe we had the wrong address. Maybe we couldn't pick them up for some reason. We need some way to nudge that member before we get to that 12 month. Because if not, then we're going to just, whether it's month 1 or month 13, the person's going to still end up in that same spot. They're going to lose because they didn't know that they had to refill out their paperwork. So, and unfortunately, that then burden kind of falls on Toy and the provider groups, right, where they're going to have to know to educate people. But it could be something where state could put a flag in a member's file, and then a provider can let them know. We can work with our MCOs, if you're a managed care state, to do better outreach to members. And we've been trying to explore those. It's never easy to reach members, but and it's been a challenge. I've been at Medicaid for 11 years, and it's been a challenge since I've been here. And we're getting better, but it's not significantly better. It's just always a challenge.
Maybe I'll move on to our next set of 3 recommendations, which will bring us up to 6. So the remaining 3 recommendations focus on financially integrating care between Medicare and Medicaid. And Matt, actually, I'm going to stay on you and say that the paper recommends that we align financial incentives using a shared savings structure that promotes integrated care over non-integrated options and captures cost reductions across both Medicare and Medicaid. It's like relatively simple to say, but hard to actually implement. It relies a lot on states, which is why I want to start with you. Can you just talk a little bit about if you were able to help lower Medicare spending, is it possible to get some of those savings back by Medicaid, and what would have to happen to make that true?
We talked about kind of sticks and carrots. This is the biggest carrot to me, like, from a state perspective. We've also talked about talking to legislators, talking to stakeholders, because if we're talking with our state legislators and governor's office administrations, and it's easy to go in and say, we have these duals, they have high needs, they're, a small population, but they're very expensive. When you start getting into, oh, and there's this Medicare Advantage plan that's called a D-SNP, and then we can make a FIDE-SNP, and then it can be an AIP, and then we can do D-SNP only. Like, I mean, you can literally just see eyes glazing over. It's really hard, like, and it's so much easier to be like, we need to fund LTSS services better, or we need to, so I think it's hard to compete in that space. And a lot of times what we're talking about too, for DSNP funding, the integration, it's admin staff. It's not we're getting more money for more services. It's we need the state to kind of build out its capacity to work with the data and to do better outreach and to create these programs and to monitor these programs. So having a carrot like shared savings just makes it so much easier to justify doing this work. So I think that's the first place to start. As far as like how to do it, I think there's a lot of different ways we could do it from our experience in financial alignment demo. Kind of the easiest way, and probably a way that the state could do it now, is just what we did was we just assumed, without having kind of no real kind of performance data to back up. It's just like, plans, we're just going to reduce your payment by 1% in the first year and then 2% in the second year, right? So that's a really blunt tool. It doesn't really get at like, are we actually saving money? Are we improving these people's experiences? And so maybe not the best tool, but one that can be used. Another one is a combined medical loss ratio. And so for medical loss ratio, anyone doesn't know, like, it's essentially a profit cap. On health plans, it says plans you have to spend a certain amount of money on members' care. And you can't go over that. If you go over that, then the state gets to pull some back. So you could potentially do a combined MLR. That starts getting a little bit more complicated. You start have to use Medicare data, DSNP data, like you get in DSNP encounter data. Are you going to do this for all duals or just those who are in an integrated plan? And it takes a lot of work. I would imagine it take a lot of work to use that data in a appropriate fashion, I guess, or in a streamlined fashion. And then I think there's the ideal, which I don't know how we get to at this point in time, which would be, let's look at the health outcomes that these members are getting and then actually say, okay, you've achieved this MCO, HMO, you're working with these members. We'll give you some money back, or states, you get some money back if they didn't achieve it. So it constantly really, we do quality withhold program. So we kind of set quality marks, quality benchmarks. We hold the plans accountable to meeting those. If they don't meet them, then we keep part of their cap payment. If they do meet them, then they get it back. So it's a little bit of a stick and carrot approach. The problem with that is data. And again, it's being able to use the CMS data appropriately. We do get our DSNPs encounter data, but using it is another, a whole nother thing, right? So right now we're just kind of using this for like research. We're just kind of getting used to it. We are going to start stepping up our use of it. But doing like a combined quality withhold program or something like that could result in shared savings. That's kind of the North Star. That's like our next step, right? Kind of, 2.0 version of our integration. So it is really exciting. It's something I think we absolutely need to shoot for. But when you kind of start talking about how to do quality within that, it starts getting a little bit more complicated.
Others want to jump in on shared savings?
Yeah, I mean, I will jump in. One of the folks, we had Washington State participated in this, and there's some more detail about Washington. Washington actually using a fee-for-service chassis through Medicaid-funded health homes was able to have a shared savings agreement with CMS that allowed it to get Medicare payments to help offset the Medicaid expenditure. So when we think about, we've had a pretty significant growth in ACOs, and so we do know how to do shared savings models on a fee-for-service chassis, and thinking about how to do more of that for states that have their duals on the fee-for-service side. And then, like Matt said, figuring out how to, in a DSNP platform, share savings with states is going to be really important. I think a couple of states, or more than a couple, have started to in their state Medicaid agency contracts, which the DSNP is required to have in order to be a DSNP, the state might require that DSNP to cover things like dental that otherwise would have been covered by Medicaid. That isn't like completely addressing the problem head on. It's sort of a reverse cost shift, but states are doing whatever they can. And so whatever we need to do to support them, whether it's a combined quality withhold, whether it's better use of Medicare encounter data, we have lots of opportunities.
Yeah, I might also just emphasize something that both Matt and Melanie referred to, which is that this is state Medicaid agencies often have tight budgets, and it's an opportunity to use Medicare dollars with accountability to help supplement those budgets if done right. And so this is the carrot that Matt referred to, potentially useful tool to incentivize this integrated care.
Rachel, before we move on, if I could also kind of introduce another idea. Sorry, I just forgot I wanted to mention it. One thing to consider if, for policymakers when we're looking at this is reinvestment of these shared savings. I think one of the things that we learned, like, we on the Medicaid side, we set a forecast. If we don't spend all that money goes back to the general fund. So if we're talking about like actual shared savings, like dollars coming back to the state, that may end up going just back into our general fund. Not necessarily the worst thing, but if we really want it, it may be a consideration of we're going to give you X amount of dollars that needs to be reinvested into care for duals. So something for policymakers to consider, but that could be a helpful tool as well.
Yeah, that's a great point. Thank you. Okay, I'm going to move on to ACOs, which have come up a couple of times. And I want to just talk about that for a minute. So we've spent a lot of time talking mostly about how Medicare Advantage plans can help develop integrated options, but nearly half of dual eligible beneficiaries are enrolled in fee-for-service Medicare. So to improve and coordinate integrated care for those enrolled in traditional Medicare, we recommended that there should be pathways to enroll dually eligible beneficiaries in accountable care organizations that are specifically for dually eligible beneficiaries and that bear upside and downside risk for both Medicare and Medicaid spending. And maybe Toyin, if you don't mind kicking us off to talk a little bit about that recommendation, and in particular, what does good integrated care look like at a clinical level, and why is this piece of integrating or including traditional Medicare beneficiaries who are duals in this conversation, why is that important?
Yeah, I think this is such an important recommendation because, stemming, as you said, Rachel, from the understanding that, half of dually eligible folks are in Medicare fee-for-service, many of those people are enrolled or are receiving care from a provider that is participating in some sort of an ACO arrangement, right? And so these are providers that have, on the Medicare fee-for-service side, opted into to starting to do some of the work of care coordination and care management for a population of folks who are dually eligible, notably, and not just Medicare beneficiaries. And so this is a way to say, let's create as many doors as possible, as many paths as possible to ensure that a dually eligible beneficiary can benefit from integration. So if they are getting care from a provider who's involved in an ACO, how do we make sure that that provider can also provide that level of integration that that member needs, that patient needs? And it's non-trivial. I think there's two components to it that we talk about here. The first is giving the provider a pathway to participate in Medicaid risk. And to actually be accountable for the Medicaid part of the benefit. And so that means that that we're actually thinking about the way in which both of those programs play together. They're not just focused on acute hospitalization reduction and the types of sort of interventions that one might focus on a Medicare ACO. They are also thinking about how do we leverage community-based services, home and community-based services, long-term care and supports. How do we understand and align across the continuum of care for that beneficiary so there is a single point of connection for them? Because otherwise, the alternative is that the member has something else going on the Medicaid side. Either they're enrolled in managed care and in managed care, Medicaid LTSS plan, or they're in fee-for-service on the Medicaid side. And there, the two are speaking to each other, and we haven't solved the problem of integration. So that's one piece. I think the second piece that you alluded to, though, is acknowledging that if you're good at caring for Medicare beneficiaries, that does not necessarily translate into the capabilities for dually eligible members and beneficiaries. And we actually have to incentivize and support and enable a real redesign of care delivery for dually eligible beneficiaries with a focus on behavioral health supports and services, the competencies around long-term supports and services that I talked about, an understanding of an ability to really invest in social drivers of care, to collaborate and partner with community-based providers well outside of the traditional milieu of healthcare, and then most importantly, to be able to go into the home and to engage and to build their relationships with not just the member themselves, but with their caregiver in their home. And so what we are hoping to sort of highlight here with this recommendation is that there both needs to be a sort of financial and operational path for providers in ACO relationships caring for dually eligible members to participate in integrated programs and to provide integrated programs. But then there also has to be a real conscious redesign and focus on ensuring that those providers actually have the core competencies to then do well by those members and to serve them effectively in a continuum of care that includes many more pieces than you would traditionally think are necessary to be successful in Medicare.
So do current ACOs fit the bill? So current ACOs primarily are located within traditional Medicare, at least the Medicare ACOs. Do we need a completely different model here?
I think it's probably the answer is probably yes and right. And so we need first of all we need willing providers, and I won't presuppose that all providers who are participating today in Medicare ACOs want to or are capable of pivoting or expanding their capabilities to serve dually eligible members. I actually think we need to think about who's participating in these ACOs and how we can ensure that these folks are opting in to taking on a broader spectrum of a care continuum for serving these populations. And then I do think it's possible to get there, but I don't think it is it's an easy or passive move. And I think that's the sort of point trying to make here is it's not just give them a pathway to have risk on Medicaid and everything's going to be fine. It's a pathway to have Medicaid to have risk on Medicaid and also the ability to incentivize capability development and best practice development to actually serve those populations well. And I think some will be really successful and others will need to work hard to become successful. But by creating that opportunity and creating those incentives, we broaden the potential for all dually eligible members who wish to have access to integrated care. And that's really the goal here.
This is a recommendation that we need to hold programs and plans accountable for meeting the needs of beneficiaries through structures and processes that promote patient-centered whole health care for duals. So some of this is related to developing quality measures, establishing ombudsperson offices, strengthening joint CMS and state oversight of integrated models. I want to start with asking why is this recommendation important?
So obviously, importance of we need to actually measure if we're being successful. So that's kind of the easy one. I do also want to put in a plug for the ombudsman program. I'd say this is one of the things that we learned in the state of Virginia through the financial alignment demo. It wasn't that we weren't working with ombuds before that, but that really kind of, our relationship got much stronger there, and we've continued that relationship ever since we left the financial alignment demo, which was in 2017. So we still work with them. We meet with them monthly. They provide reports to us, and so and a lot of it does have to do with duals because they are touching people with long-term care needs, and so they see a lot of duals. I would just encourage other states, other kind of policymakers to make sure that they are part of the solution as well. And ombudsman can advocate for themselves, but they're probably going to need more researchers as well. Like if we're going to establish a stronger ombudsman program or kind of expand what they're doing, I know just like they are state staff generally, and so they're going to need more support as well. The other thing I would say just kind of about quality is just, I think it goes back to something we were talking about before with like shared savings and quality measurement. I I think it's really hard to have the kind of these shared quality measures and kind of quality withhold program because again, the data is not there. And so I do think this would be, again, it's something that I think we want to shoot for. At least from the perspective of Virginia, it's something that we want to try to get to more and try to explore ways with MMCO, who has been fantastic partners with us. But I think it's a barrier because using the CMS data and using state data and combining them and using it kind of quickly in a way that's going to make sense is just a really real big challenge.
Aisha?
Yes, well, I think that, it certainly goes a long way to establishing trust for the beneficiary as well. I think having any kind of oversight organization or entity lets beneficiaries and their families know that there is a ability to put in place measures that we can count on to see what it is that is making sure that are quality services being put in place, quality plans, making sure that that there are that what's available can be trusted, and that we are not kind of just idly choosing things that have not been vetted, where there's no one looking over the processes and those sorts of things. And I think that having oversight can go a long way to creating this sense of assuredness in the process that again is very foreign to a lot of people, that is very unclear, where there is confusion. But I think bringing in that trusted agency can really facilitate that process for a lot of people.
We do have a bunch of questions from the audience, and I want to get to a few of them if we can. One person is actually asking about PACE, and so we haven't talked about PACE. One of you can remind me exactly what PACE stands for because I can't remember off the top of my head. But it's a program for older adults, and you have to have a nursing home level need for a nursing home level of care to be enrolled in PACE. But it's one of the programs that has a pretty good level of evidence about its effectiveness in both improving, integrating care and actually saving money for dually eligible. So the question is, why not encourage states to consider encouraging the PACE model?
We actually have a fairly robust PACE program here, I think, compared to other states in Virginia. I think the challenge with it is that it is limited on where you just can't scale it up to offer it everywhere. I think it is because it is kind of centered based. You're gonna have to transport people back and forth, and it's just not something you can really do, particularly in rural areas. I think that's from what we found. So, absolutely encourage it. We've taken measures to try to educate members about PACE programs. So when we send members when they're new to Medicaid, we're going to be enrolled in managed care. If we know that they're a dual, we send them information about PACE as well. We have our screeners who are out doing long-term care screenings to see if someone meets nursing facility level of care, which could get them in a waiver, could get them in a nursing facility, but it could get them in the PACE program. We have them educate the person about PACE as well if it's in their area. But again, it's not an easy model to stand up in a lot of places. I think it's just a little bit limited.
Yeah, I would just add that, we've been talking today about the services and the experience integrated, but also the finances integrated. And PACE is not a financially integrated program, which sometimes makes it difficult for states to understand the value or kind of like how Medicaid and Medicare dollars are being used. And I think PACE might see greater uptake if we could get a little more transparency on the financial interaction between Medicaid and Medicare and how that impacts the care that people are getting and how that any savings are getting reinvested into the system.
Just the overall theme of these recommendations was really about, as we talked about earlier, encouraging as many pathways for integrated care for dually eligible members and beneficiaries. And PACE is one solution. It's not going to be the only answer. And it certainly is much more challenging to scale than many of these other approaches that we've talked about. It's more capital intensive for providers to deploy. To Melanie's point, it is not doesn't give as much leverage to states and as much visibility to states in terms of where the costs come to play. And so, while PACE is one part of the answer, I think what we're proposing here is that there has to be actually a much broader tent through which to capture and create opportunities for dually eligible beneficiaries to benefit from integrated care.
I wonder if we could so the setting in which we had this conversation over the summer is that there had been a couple of bills introduced in Congress to address improving integration, enrollment in integrated plan. We are now in a different time, a few months later, where there's been an election and there's some uncertainty about what the future is going to look like and what rulemaking is going to look like. But I wondered if we could just go around this virtual room and hear from each of you about how your thinking has changed since the election and what you think specifically about the possibilities of achieving integrating care now. Like, what are the paths forward?
There is hesitation for me. It's certainly, I think, just the climate and the landscape politically creates pause because, as this is a bipartisan issue, um, it's something that um, requires collaboration across the aisle. And I am very concerned that that's not something that can be as easily achieved. However, there is hope. I do hope that that civility would prevail, and that the understanding for the need of millions of Americans to not only receive coverage, but receive quality coverage, and to achieve uh, the best health outcomes possible. I think, is something that, it's a very strong argument, that can be made regardless of party. So that would be the optimism within me kind of overriding the pessimism that can creep in at times.
Matt, where do you think Medicaid is headed?
Oh, yeah. So first, I generally defer to Melanie. She knows the federal landscape much better than I do. But I would say, from my experience, both at the state level and also from what I see at the federal level, it generally is a very bipartisan issue. Our problem isn't that it's not supported by Republicans or Democrats; it's that it's complicated. And then the funding needs to go to admin instead of maybe for services sometimes. But yeah, so I don't know what this new administration is going to want to prioritize, but I'm still optimistic that we'll continue to operate in this bipartisan fashion around this issue, at least.
Yeah, I mean, I don't think anything changes in terms of the needs and the opportunities. This is still like we still need to support states. I think what does change is making sure people understand that if the Medicaid program is underfunded, it will have an impact on the ability to do integration. And sometimes people forget that a dual is part Medicaid and part Medicare, even though we talk about it all the time. Also, just want to put a plug in that this is why I was smiling earlier. If we were stepping back and saying, what would we do that would make the lives of people with medical, behavioral, long-term care, and social needs better? We would not have them navigate two programs, nor would we have providers navigate two programs. And if we're going to build the capabilities Toyin's talking about, we can't make people understand the different standards between DME and home health, for example. I mean, that's the greatest example we have for this population. Those services are so needed and it's so hard. And so I'm hopeful that as we look at opportunities to make the system more efficient for both Medicaid and Medicare, this notion of a unified program might be back on the table. Sorry, I was going to take an opportunity to get that in there.
I was going to get there.
I know, but I'm looking at the clock, and I know Toyin will have some good words of wisdom.
No, I think that's it. I mean, change is anxiety provoking, and there's a lot of unknowns. I think there's a lot of desire to start to prognosticate. I think it's too early. We need to wait and see. But I also like everyone, like Matthew said, believe that this is a truly bipartisan issue. We all are invested in ensuring that the folks who have the most complex, most challenging needs in our healthcare system and who are also disproportionately high cost to the healthcare system have access to care and services that are going to improve their experience and their outcomes and manage their costs in a way that's effective and appropriate. That's just a sort of it's such an aligning point of principle. To Melanie's point, though, we certainly have not designed a system that necessarily makes it easy to achieve those goals to date. But for as long as I've been in this space serving dually eligible members, which is essentially my whole career, we've made real progress. And it's easy to get sort of mired in the like one or two or three or four policy recommendations you want to see this year or next year or this legislative cycle or this administration. But when we look back over the course of the last decade, we've made tremendous progress in understanding the needs of this population, describing the needs of this population, and starting to create more and more pathways and proven models that actually deliver outcomes for them. And so that gives me hope and optimism as we look forward for the next decade. But there's going to be a lot to navigate here, both at the state level and at the federal level in the next 6 to 9 months for sure.
So I want to do something really quickly. We just have a couple of minutes left, but I want to return to this point about, all of our recommendations are about trying to integrate these two separate programs and make them work better together for people who are dually enrolled. The alternative is what Melanie brought up, which is that we create a new program, which is a single standalone new entitlement program, Medicare Part E, which is for dually eligible individuals. And I want to when we ended our convening, we went around the room and everybody had to say how feasible they thought that was and how impactful they thought that would be if we were to do that. And I guess I would like to hear from each of you. We only have a minute left now about feasibility and impact and maybe just why, like briefly, why motivate your answer. And so Melanie, I know that you're enthusiastic about it, so maybe I'll start with you.
I'm going to say impact 10. We're on a 10 scale.
Sure. Yeah.
Feasibility, I'm going to go with, 7. If we have support for states and we can support CMS in getting there. I think we wouldn't have to we'd have maybe different challenges, but the ones that we make people do today in navigating these programs would be essentially taken care of, and they would be able to interact with their insurance provider like you and I do, which is something they cannot do today.
Matt, do you want to go next?
Yeah, can I just say ditto? Because I think that's where it's at. Like, as to Melanie's point about feasibility, as long as there's resources for states to help us kind of make that shift, assuming that it's going to come to the state to operate the program, which may not, but assuming that it does, we would need some resources to kind of particularly to help stand that up and get that going. But if that's the case, then yes, impact is 10, and I think it's possibly exactly the right thing to do.
Yep. Aisha?
I echo everything that's been shared here. Yeah.
Great. Okay. And Toyin, last word.
Yeah, I guess my last word is YOLO. I think this is like, when things are disruptive and when things feel a little like, anything could happen. You've got administration change, you've got just a lot of kind of variables. Like this could be a 10 out of 10 feasibility moment where, anything could go. And I think being ready, I will just have to shout out to my friend Melanie for having spent so much time laying the groundwork for not just this, but a whole series of really well thought out proposals that are almost ready to go, And so if there is will, we certainly have momentum and there's enough kind of attention particularly on cost savings within the healthcare system. We've got a plan ready to go. And this could be the moment. So I'm optimistic. I think this could be the time.
Great. Okay. Well, I love the optimism. I hope that we get there. And I want to thank all of you for joining us today for this conversation. It's been a really great conversation. I also enjoyed working with you over the summer to talk through these challenging issues. Thanks to the audience for joining us today. And I hope everyone has a safe and happy new year if we don't see you before then. Thanks, everyone.
you.